Okay, so today with us we have Nicole Merman and Sarah Matthews. They are graduate nursing students at the University of Texas Hook'em Horns. And each Tuesday we have Longhorn Talks with the Nurse, and today's topic is related to depression, myths, and facts. And so I will turn it over to them. It is being recorded, but the person who is editing the version of this presentation will crop out the people. So if you're concerned about that, since we didn't ask permission to have you recorded, they will crop you out. So I will turn it over to them.
All right. Thank you, Dr. Horton. So let me just see if this screen sharing works like it did last time. Please bear with me. Oh, it says that I can't screen share. It says cannot host disabled, maybe?
Just hit refresh. Try it again.
Okay. Can y'all see that? Can everybody see that okay?
Yes.
Yes. Yeah.
All right, excellent. Okay, so yeah, as Dr. Horton said, and we kind of met some of you just a few minutes ago, but I'm Nicole Merman, and then we also have Sarah Matthews over there. And we're grad students. We're also on the psychiatric mental health nurse practitioner track. And today we want to talk to you about some facts and myths related to depression, which we think is particularly relevant right now with everything going on with COVID-19 and having to stay home and self-isolating and things. So let's see. Okay, so I want to just start off just by framing our discussion by offering a definition of depression. Before I give what I have down, I want to hear what your thoughts are about what depression means, if you're willing or able.
Let me unmute everybody. Go ahead.
Yeah.
Well, this is Diane, Shalonda's, Dr. Hartman's mom. I just feel like depression is just like loneliness, feeling like you are not loved.
Mm-hmm. So yeah, definitely touching on the social aspect of depression for sure. Does anybody have any other thoughts?
Just like negative.
That it's like a feeling of self-worth, not feeling good about yourself.
Mm-hmm. Mm-hmm. Definitely. Low self-worth.
I would say, I'm sorry, y'all can't see me right now. This is Barbara. But I would say depression is when you get to a point where you're unable to do your daily kind of routine or functions. I mean, get you to the point that you can't really operate like you normally would.
Yeah. Those are all really great, pieces of the definition for depression. You really touched on everything in terms of the social aspect, the intrapersonal aspect, and what feelings might be involved. So you guys really hit the high points, but I'm still going to give you this general definition that we'll go over together. I don't know why it does that. There we go. So depression, you guys may have also heard it called major depressive disorder or clinical depression. It's a common but serious mood disorder, causes severe symptoms that affect how you feel, think, and handle daily activities such as sleeping, eating, or working. So all of your definitions definitely touched on this very broad one. So great job, everybody. So now that we have a sense of what depression means or an agreed upon understanding, I'd like to just go over how common it is. So looking at the prevalence rates. So according to the CDC, 8.1% of American adults had depression in a given 2-week period between 2013 and 2016. And to give I like to think of it in terms of how many people you see. So how many people you pass by. This is like saying 1 in 10 people adults that you see have had depression or maybe are currently experiencing depression. So that it's really just highlighting how common of a mental disorder it is. And then this graph that you see, it's not meant to be intimidating in any way, even though graphs kind of intimidate me sometimes. But it just kind of offers some more specifics. So you can see that in looking at sex, so we have both sexes in the first clump of bars, and then we have men in the second clump, and then women in the third clump. And then within each of the sexes, we have it broken down even further by Hispanic origin and race. And so we have the dark blue bar indicating people who indicated that they are of Hispanic origin who have depression. And then we have the medium blue bar, which is representative of non-Hispanic white people. We have the light blue bar, which is representative of non-Hispanic Black people. And then we have the green bar, which is representative of non-Hispanic Asian groups. So it's definitely not important for you to memorize these numbers or know the specifics, but just to give you a sense that it really affects all people, all ages, all sexes, and all ethnicities. Yeah, so even though depression is so common, it's still something that's highly stigmatized, along with really all forms of mental illness. And I kind of wanted to hear from you guys. What are your thoughts in terms of the definition of stigma or how it may affect people? Yeah, it's tough.
Yeah.
If you're on the phone and you're trying to make a comment, you'll just have to hit *6 to unmute yourself.
Could you repeat the question, please?
Sure. Yeah, so basically just saying that depression is very stigmatized. There's a big stigma around depression, along with other forms of mental illness. My question is, what are your thoughts about what stigma is and or maybe how it affects people?
I would think that a lot of people, they won't admit that they have it because of the negativity that is associated with it, but at the same time, they're never able to get the help that they really need.
Yeah, that's fantastic. Does anybody have any other thoughts about stigma or the negative effects it can have?
I think that it's more prevalent. The stigma is more in Black people because they do not want to. They want to keep it quiet if they do have depression, and it will go untreated for a long time. I think that's one thing with us Black people that we don't like to admit if we're depressed.
Interesting. Great, yeah, thank you for that contribution. So yeah, really, you guys hit the nail on the head again in talking about how it can prevent people from getting the help that they need. So the stigma, which includes, negative perceptions, as one of you mentioned, negative perceptions of people that say they have depression, and then the associated discrimination that goes along with that and misunderstanding about what mental illness is may prevent people from feeling like they can seek the help that they need. And so our goal today is to discuss the myths and provide education about depression in hopes of reducing that stigma. And so we'll be going on to our first myth, and I'd like to hand it over to Sarah.
So the first sets of myths we'll talk about today are myths such as depression is the same thing as being sad, or depression is being in a bad mood. And while these describe fleeting feelings of emotion, depression is a disorder like heart failure or like diabetes, and where there's clinical criteria for it. So those include, as a treatable mood disorder, there's multiple symptoms that make up depression, which we'll talk about. But an important thing is that these symptoms last longer than 2 weeks, And the person with depression feels these symptoms most of the day, nearly every day. Another important component is that depression causes significant distress or impairment in areas of functioning, such as your social relationships or your academic work, your career, things like that. So what are some symptoms that y'all think people with depression may experience? Some of the things you've heard of or are aware that can make up depression?
They lose interest in hobbies that they used to have.
That's spot on. Does anyone else have any other symptoms?
Yeah. There also might be isolation, like self-isolation.
Some people have trouble getting out of the bed, going about their normal tasks.
Yes. Okay, great job. Those are all, yes, definitely examples of symptoms.
And
So,
self-care. Crying a lot.
Okay, good job, everyone. So some more examples of symptoms. So we can see continuous negative feelings. So we see sadness, anxiety, and emptiness, but we also see feelings of hopelessness or worthlessness or pessimism. We see changes in energy. So someone could be fatigued, their talking or motions could be slowed down, but they could also be irritable and restless. We see changes in appetite as well as weight. So that can be weight gain or weight loss. We see someone mentioned issues with sleep. So not being able to get out of the bed, trouble going to sleep, or maybe awakening early in the morning. We see issues with memory, concentration, which also affects decision making. One thing that people don't always consider when we see depression, there can be physical symptoms such as pain, headaches, aches, cramps, digestive issues that might not have a physical cause, or they might not improve with treatment as well. Someone mentioned one of the hallmarks of depression is losing pleasure or interest in things that once brought joy. So that could be hobbies or relationships with others, where you're just not getting that sense of joy that you once did. And then the last one of the most serious ones, there can be thoughts about death, dying, or suicide, and that also includes attempts at suicide. So the next myth that we'll look at, a misconception that sometimes people have, is that depressed people cry a lot. And we want to mention, while this is true for many people, a person with depression could still be depressed and not display that. So we just wanted to highlight that there's a range of experiences someone with depression could have. People have described it as feeling empty, numb, or blank, and just a general sense of worthlessness or usefulness. So it's just important to note that it doesn't always manifest as sadness, although people express emotions as well as the symptoms of depression differently. So some examples we might not think about are increased forgetfulness, self-isolation from friends and family, which is what someone else said, or also just reduced performance in work or school. And you can also see self-harming behavior, such as hurting yourself by cutting or things like that. So it's just important to remember that depression, it shows up in different people in different ways. And then another one is that all depression is the same. So far we've been talking about what's considered major depressive disorder, but we just wanted to highlight that there's a few types of depression. So other types include one called persistent depressive disorder. It used to be called dysthymia. And what this is, it's low mood lasting for at least 2 years. So you won't see as severe of symptoms as you do in major depression, but they're for a much longer time span. So the person may be able to function day to day, but they may feel joyless or low most of the time. Another one to consider is perinatal depression. It was formerly called postpartum depression, but this is depression during pregnancy and as much as 12 months after pregnancy. Some people talk about baby blues, which is pretty common the 2 weeks after birth to feel tired and feelings of anxiousness, but perinatal depression is severe depression, and the feelings of sadness, anxiety, and exhaustion may prevent mothers from taking care of themselves, and also interfere with how they care for their infants. And then another one that's less commonly known is seasonal affective disorder. And so this is a type of depression that occurs mainly during the fall and winter, and it has to do with our body and the natural light and how our body responds to that. So as the days get shorter and we have less light, people might get more depressed in sort of a cycle, but then that depression may alleviate in the summer and the spring months. Just as when you have a poor mood during rainy days, it's like that, but on a bigger scale, where someone could feel depressed an entire season. And then the last one I'll talk about is psychotic depression. So that's depression, but it has elements of psychosis. So someone still may have low mood, but they also might have delusions, which are false fixed beliefs, or hallucinations, which is hearing or seeing things that are disturbing to you that other people do not hear or see. And with that, I'll hand it back over to Nicole.
Real quick, Sarah, on that next slide, could you just go over the first one? It froze a little bit, just how long it lasts, the first one.
Oh, yes. So the persistent depressive disorder, that one lasts for at least 2 years. So a much longer span of time versus the 2 weeks for clinical depression.
Can I ask a question about the perinatal depression, the name change?
Yes, definitely.
Did you say is that more so that more women were being diagnosed as being depressed like during pregnancy versus it just being afterwards? Is that what you said? Did I catch that right?
Yes, that is exactly correct. So the common conception with postpartum depression was that it occurred just after you had the baby, but they've found out that even starting in the early stages of pregnancy, that some women can get this form of depression, and also just highlighting that it can go from pregnancy all the way to 12 months. So they renamed it just to capture that bigger time span that this depression can occur. And it should also be noted, there's been research that fathers can also have these sorts of depressive symptoms during this time span of adjustment. But it differs from baby blues in that it needs more serious treatment because the symptoms don't always go away on their own.
Okay, thank you. And I had just one other question. What was the name again of the type of depression that's the low mood that can last for like a couple of years?
So the term that they call it now, it's called persistent depressive disorder. It was previously called dysthymia, which some people still refer to it as such, but it's persistent versus major depressive disorder.
Okay, thank you.
Sure thing.
Awesome. Yeah, thank you so much all for your great questions. The next myth that we have here is depression only affects women. So I think we know it does affect men as well. So it affects both genders, all ages, all ethnicities, and all cultural groups, as I've said, I think probably a couple times before. I want to hear your thoughts on this one. So what is it about this myth, or what is perpetuating this myth that depression only affects women, do you think?
Typically because we show our emotions more.
Yeah. Men are supposed to be strong.
Yeah. I mean, really, that's, oh, did somebody have something to say? I see a highlight.
Because sometimes like men like hide their emotions sometimes.
Yeah, absolutely. I mean, all of those relate to exactly why we see a higher incidence of depression in women. It's really men really underreport their symptoms and may not seek treatment as often as women do. And so it appears, even in that graph that we saw at the very beginning, that men have lower rates. However, it's believed that the rates are about equal. It's just men don't get the help that they need for all the reasons that you guys stated. You know, they just are maybe more conditioned to be tough and to not show emotions, all things of that nature for sure.
And I would just add, I think that just unfortunately goes to men and health in general. So physical health, mental health, men just don't typically seek help or even preventive or when something's happening unless they a lot of times have a woman that fortunately pushes them to go get seen.
That's interesting. Yeah, I usually think of I think Sarah and I both being on the more in the psychiatric realm, we think a lot about mental health, but it's really important that this can be seen in physical health too. I could see how that difference can still persist into a lot of different conditions. Just men feeling like they can't get help. So thank you. Thanks everyone. So the next myth, this is one of, I don't know, I hear this one quite a bit. Depression is all in your head. The fact of the matter is, as we've been discussing, it's a mental disorder caused by a mixture of factors, including social, genetic, biological, and environmental factors. So really the effect that this has, if someone were to hear it's all in your head and they're feeling currently depressed, that's going to really invalidate their experience of depression. And it can really make them believe that they're alone because they have all of these issues related to the depression, but people are just like, oh, it's just in your head. I can't see it, therefore it's just in your head. So this is a detrimental myth that you need to try to avoid saying for sure. And then the next myth, having depression means I'm weak. So unfortunately, mental illness is often tied to being weak in our society, something that in the mental health field, we're really trying to fight against because it's just simply not true. The fact is, depression stems from a combination of risk factors, many of which are outside a person's control. So again, I want to hear from you guys. What are some examples you can think of that might be risk factors for depression, or what are some things that can increase somebody's risk for getting depression?
Life situations that happen, death.
I think someone that, oh, I'm sorry, go ahead. Okay, this is Shalonda's mom. I think someone that's always trying to do things, be self-reliant and not try to get help and getting things done, or don't want to ask somebody for help, for ashamed to ask. I think that could be one of the risk factors.
Definitely. Anybody
Chronic, yeah, I would say chronic stress. So consistently being in situations where you are stressed and just stressed out.
Yeah, definitely. I mean, you guys really, again, are just kind of capturing all the elements of this. So we talked about kind of the stressful life events. So it could be things like having a stressful job, or maybe you've experienced something traumatic. Somebody mentioned death, which I guess one quick distinction. So if we experience an acute event and you have some depression related to that event, that's really like you didn't have it before and you don't have it kind of after the grieving period. We look at that as more of a reactive depression, kind of going along with there's so many types of depression, but we wouldn't encompass that under this major depressive disorder. However, it can totally make your depression worse if you do experience a death, maybe in your family, while you are in a depressive episode already. So I also, like somebody mentioned, kind of the intra-personal processes, just the way that you handle emotions can make you more susceptible to depression. All right, thank you. Here's another myth. So you can simply snap out of it, or hard work beats depression, or just think positive. So the problem with these is that none of these statements represent ways to actually manage depression. And in fact, by saying these things to someone with depression, it can lead to feelings of helplessness and worsen depressive symptoms. Because really what these statements are getting at are why don't you just fix it? Or you should be able to change. And so it's really making the person who's experiencing the depression have this set of unrealistic expectations on them, and adds a burden to them in addition to the burdens they're already experiencing. And then they can feel some sort of self-blame, just like I can't change. Everybody thinks I should be able to change, but I can't. You know, something must be wrong with me. Does anybody have any comments about that? Have you guys heard this myth a lot before?
No.
Okay. All right, thanks guys. So I'm gonna pass it back over. Oh no, I do have one left. So depression isn't a big deal. I feel like this goes along with kind of, you know, it's not physical. You know, it's not like you're dying or anything. You know, people can kind of make these comparisons where it's just like, you know, it kind of goes along with it's just in your head, like, it's not a big deal. But as we know, it can cause significant impairment and suffering in a person's life. And going back to the CDC at the presentation, about 80% of adults that they interviewed said that they had some sort of impairment in different aspects of their life, whether it be work, social, or even their home life related specifically to depression. Another thing to note is it can actually worsen medical conditions or put you more at risk for medical conditions. So we see in things like heart disease and diabetes, even cancer, that it can worsen prognoses, worsen the prognosis if you're also concurrently experiencing depression. All right, now I'll pass it over to Sarah.
Okay, so our next myth is medication is the only way to treat depression. Does anyone know other ways to help manage depression that come to mind?
Cognitive behavioral therapy.
So that is a great example. So we just want to highlight medication. It's certainly one way to manage depression, but it's not the only way. Depending on the severity and the history of symptoms, depression is often treated through medication, therapy, such as cognitive behavioral therapy, or a combination of the two. But other activities can definitely help with depression. Those could include spiritual or religious practices, such as prayer, in addition to things like meditation, exercise, talking to loved ones, and a regular sleep schedule. So families, friends, and faith communities can provide support and promote healing. However, it's important to note that depending on the severity of the depression, seeking professional help in the form of healthcare professionals that could provide medication or therapy may be necessary. And then our last myth is antidepressants cure depression. So depression, it's a serious mood disorder, but it is highly treatable. Depending on the person, their provider might have them be on a certain antidepressant medication for a certain period of time, and it might take a little bit of trial and error to find one that works best for them. But when their depressive symptoms start to go away, it doesn't mean that they're cured and should stop taking antidepressants immediately. Doing this can cause a worsening of symptoms because the relief the person was receiving was due to the medication. So a person should never abruptly stop taking medication or change their treatment plan without talking with their provider. So through working with your provider, you can create an action plan that will help you reduce or stop your medication in the safest way possible by allowing your body to adjust. And so one last thing we hope you take from our presentation is that how important it is to seek help when it's needed. So we wanted to ask if anyone knows who they like to ask for help, if you guys have any resources through your church or any community resources that you found as ways to reach out when you need help. Does anyone have any examples they can think of?
You have to press, what was it, Dr. Horton? You have to press *6, I think, to speak. If somebody's trying to speak who's calling in, I think it's *6.
Yes, if you're wanting to share and you're calling in, it's *6 on your phone.
Mm-hmm.
There are several agencies that we can reach out to, like NAMI. At Mount Zion, we also have the Amen program, which has a healthcare professional for mental health as well as physical health. But NAMI is a good resource. Integral Care is also another resource.
Yes, that is great. We are so thankful that there's more resources and that they're doing a lot to promote helping others and just making awareness a bigger part of their agenda as well. So we included some ways to reach out, and you guys already hit on NAMI is a big one. So for those who don't know, that is the National Alliance on Mental Health. Other things we recommend are talking to your doctor or a health professional, mental health professional. In times when it's needed, there's also a crisis hotline number, and a component of that is also a veterans crisis line. We encourage people to reach out to a close friend or a loved one, as well as people in your faith community, such as a minister or a spiritual leader. And like NAMI was mentioned, they also have what's called a faith net. And so that's an interfaith resource network that provides tools and information and other resources to help educate and inform about mental illness such as depression. And then
Sarah, I wanted to just add one more for people who, for youth or young adults, LifeWorks is another resource in the community people can tap into.
Thank you, Dr. Horton. That's a great one as well. And someone mentioned Integral Care, which is for Travis County. So there's definitely resources in the community for you or for a loved one if you think they're experiencing or could be experiencing depression. And the last tidbit we wanted to include before opening it up for discussion is that there is a free online youth mental health first aid certification program. It's Saturday, April 25th from 9 a.m. to 2 p.m. It'll be an online class that'll be aimed at helping young people dealing with crises or other mental health issues. And if you're interested and available, we definitely encourage you to sign up. We've heard that it's filling up fast, so we would encourage you to use that link or through our PowerPoint or through your faith community to sign up for that free training.
Yeah. And Dr. Horton, did you have anything else you wanted to say about this in particular?
It's been sponsored by the Amen program from the School of Nursing. It is free, and the certification is good for 3 years. We are encouraging people who are 18 years and older. If you work with youth or if you're a parent or a caregiver, we think you'll gain skills to help you recognize when young people need help and how to connect them to resources.
Anybody have any questions about that?
No.
So our next slide is just our references, which are the sources we used for our presentation. And then our last slide, we want to thank you guys for listening and being so willing to offer tidbits and things like that. And we would like to open it up for any questions or comments that y'all might have after our presentation.
Thank you so much.
Dr. Horton had mentioned that this presentation would be available. Has that information gone out yet?
I'm hoping Dr. Horton can maybe help us answer that
I
one.
was trying to find my mute button. So as far as the recordings, they have not been edited yet to share. As far as the PowerPoints, I do have those now, and I will send those. I'll ask Reverend Horton and Sister Mercer what's the best way and get with our web team how to share that with the Mount Zion group. Others on the phone, you know, I'll probably just post them on the health ministry webpage. That's what I'll do. And that way people from outside of Mount Zion can still get to it.
Thank you.
Hmm.
A question in regards to your doctor, or in a lot of cases now, you know, we see nurse practitioners when we go into the doctor's office. What should we either expect, or what should we be asking or looking for in terms of them as our health provider to assess our mental state of being when we go in for a visit?
Yeah, so I can start off that one. So we do have, in particular, there's kind of two parts. So in particular, we have psychiatric nurse practitioners. And so if you're looking for somebody specifically to assess your mental health and help establish a treatment plan, there are definitely nurse practitioners that do that, which I think you're saying that you get that part. Are you then referring to how would you as an individual go about selecting which nurse practitioner or which psychiatrist you would like to see?
No, I just meant, you know, you go in for a visit with your doctor that it may not be, it may be your primary care physician.
I see.
And, right. And so I'm thinking if they're kind of your first line of medical access, then how do you make sure that, you know, I guess that you're utilizing them, or that they are, along with assessing your physical health, that they are somehow getting to your mental state of well-being?
Okay. Thank you for expanding on that. That helps me in answering your question. So some doctors, some primary care physicians, I think it's really up to their comfort level, but I think more and more primary care physicians are becoming more comfortable with treating depression. I think that others will like to refer you out for psychiatric care. So I think it really depends on their comfort level, whether they feel like they can adequately help you with treatment, or whether they think it's kind of out of their scope to the point where they have to refer to outside people. Sarah or Dr. Horton, did you have any insights about how that?
So one thing is, I think there's been a move to make assessing for depression or other sorts of mental disorders more a part of a standard checkup and things like that. But as we know, if you're focused on maybe your heart failure or diabetes or something, and those appointments are of a limited time, they may not get to that. So it can be a difficult situation in where you may have to advocate for yourself, mentioning how you've been feeling these feelings, the symptoms, whatever you or your loved one has, and really expressing to them that this has gone on for a long time. It's not really a passing emotion I'm feeling. It's something that I'm living with and it's affecting me. So if you're going to a primary care, it might take some effort on the part of you, might have to advocate for yourself and saying, I've been not feeling great. It's not going away. I think it's something more serious. In the case, if they're not really looking for that, if they're looking more at other physical symptoms or things like that. But there is a push for providers, primary care providers, to be more cognizant of things such as depression when they're doing their checkups and things like that. But for a matter of time, you might have to kind of lead them in the right direction so that they know this is a concern that I'm having, unfortunately. So that's why going to a specialty care provider as a next step is a good option, because they'll be more tuned to those sort of problems or what they should be looking for in order to diagnose and treat appropriately.
Could I piggyback on that? This is Jeff Brazell, Dr. Horton's dad. And I found recently in going to see doctors, in the paperwork, if you have not seen them in the past year, a lot of doctors now, you know, they have a packet of paperwork that you have to fill out. It just drives me sometimes. But anyway, they will ask you, there's a battery of questions that they will ask you about, have you been experiencing any of these symptoms? Mm-hmm. And so naturally, right, if you check the box, then that primary care physician or that doctor is going to take and further expound on that with you. But if you do not, and you know, like was said earlier, that sometimes you have to take and be cognizant of your situation, to where if it's just a routine, you're going in to get a physical, or you going in every 6 months and not having to fill that paperwork out. And let's just say previous 6 months, everything was cool and you didn't have that trouble. But the next 6 months, if you didn't have to fill out any additional paperwork, you just might need to bring that up to that primary care doctor.
Mm-hmm. That's a great point. They're trying to incorporate more of those surveys that sometimes they don't. They're trying to make them sometimes shorter so that they fit into the appointment, but sometimes it might not cover the full depth. So I think that's something that primary care practitioners are trying to grapple with. How can we make this more integrated in the care that we already provide, while still being able to treat every asset of a person and making sure they're cared for, not just their physical things that may be most salient to me at the time. Anyone else have any other questions
or comments? You know,
how would you address someone if you feel like they have depression? How would you go up to them and say something to them?
That's a great question. So you mean in trying to encourage, so is this a person who doesn't, has never identified with having depression, and you are hoping to help them get treatment? Is that?
Yes.
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 Okay.
I wish I knew like the perfect thing to say, but it is really so dependent on the person and your relationship with them. But I think the most important thing is just showing that you're coming out of a place of love and care in a way that's not accusing. Because if a person experiencing depression might already feel worthless, if they're feeling like you're coming in and saying something that might be misconstrued as being attacking, or saying that they haven't lived up in one of their roles as a family member, things like that, but just showing like, I'm coming to you because I've cared. How are you doing? How have you been feeling lately? How have you been doing emotionally? I think also during COVID-19, just really checking in with people and just saying, this is a really difficult time. How are you handling it emotionally? Is there anything I can do for you? Really just being someone that is there to listen and just show, I'm here for you and I want you to be happy and have joy and live your life with the most joy as possible. So it's hard because we wish there was just better statements that were universal that we could give, but I think it's really just dependent on how do you connect with this person and what do you know are they comfortable with and what you're comfortable with as a loved one reaching out.
That's good. Thank you, Sarah. And I just want to add to Sarah's, especially when you're trying to connect with that person, if you notice a certain behavior, you can just say, I've noticed that you're not around the family as much, or I've noticed that you're not eating as much. I'm concerned about you. And I want to hear what's going on in your life. And if they do go ahead and open up, you say, well, may I go with you to your next appointment? Here's a phone number. I can three-way call with you. So they just know that you're just wanting to help them connect. or if they had a death in their family recently, you could say that could be hard to go through. So just address the elephant in the room. That, you know, your mom just died. I'm just checking on you. How are you coping with this? And then just listen.
Okay. Thank
You
you.
know, I think those questions, I think two questions kind of come to mind that are very non-threatening, in that you see it in their face, first of all. And if you have that relationship with them, or maybe if you don't, more or less if you don't, you know, you tend to want to ask the question, are you okay? I think that's very non-threatening. And can we talk, or would you like to talk? Would be, I think, a follow-up question to that, perhaps.
Okay. Thank you all.
Thank you. And the last thing I want to highlight with the NAMI organization, they have support groups for the caregiver, because it might be a person who's taking care of a loved one with depression, and they have support groups for the individual. And so you can link them to NAMI, and sometimes they just that might be just one too much thing to go look up, and you can look it up for them and send them the link.
Okay.
Okay, well, if there's not any other questions, could y'all please help me thank these amazing graduate nursing students?
Thank you.
Thank you. Thank you.
Been very helpful.
Thank you.
Thank
Good
you
job.
all for joining us.
Good job.
Thank you. Thank you.
Our next Thursday is our Longhorn talks with a Longhorn nurse for the youth, and they will be covering lung disease, anywhere from COPD to vaping, e-cigarettes, and it's at 11 o'clock using the same link. And then next Tuesday is for adults, and they will be covering how to eat healthy in the midst of a pandemic. So same link, 11 o'clock on Tuesdays is for adults. Young people are welcome too, but Thursdays are tailored just for young people, and parents are welcome to join that too. 11 o'clock, no, I'm wrong. 11 o'clock on Tuesdays. Thursdays is 3 o'clock because the young people are in school. So 3 o'clock Thursday, I apologize. I think it's 3 o'clock. Is that what time we did it last time, Tanya, if you're still on here?
I think so.
Okay. I will send a reminder. How about that? Okay. Well, thank you all so very much. Y'all have a very blessed day, and I will stay on the line here with the students so we can debrief.
Thank you so much.
Thank you.
Thank you.
Thank you.